Hello everyone, hope you are all doing great. We are going to discuss about internal genital organs in this video. What are the internal genital organs in the female? We'll see the uterus, adnexal structures, that is nothing but the fallopian tube, and ovaries, and then we'll have the vagina. First we'll discuss about uterus. So uterus is a pear-shaped organ. It is located in the pelvic cavity. So if we see the uterus, the structure will be like this. Okay. So first, okay. So these are the fallopian tubes. Okay. And this is the vagina. Fallopian tubes and vagina. Okay. Now this part of uterus consists of, so this is the body or corpus of uterus, and this portion of uterus that is extending above the fallopian tubes is the fundus of uterus. It is a dome shaped structure and that is extending into the vagina. Okay, this lowermost portion, as it is, this region is called as the cervix. Okay, now the junction between the body and the cervix, okay, say this part. Okay, so this part is basically known as isthmus. Understood? Now we'll see measurements of uterus. Okay. See, uterus is the only organ that is capable of expanding into an abdominal organ also, physiologically especially, and it is capable of retaining its. Uterus is the only organ that is capable of expanding and becoming as an abdominal organ physiologically, and it comes back as a pelvic organ after delivery. And this happens more by hypertrophy than hyperplasia. Okay. So we have to know the measurements of a gravid uterus and a non-gravid uterus. Okay. So first we'll see the measurements of non-gravid uterus. Non-gravid uterus is generally about 6 to 8 centimeter in length, and it is having a capacity above 10 to 20 ml. Whereas a gravid uterus can expand much and it is capable of having a 5 liter capacity. So basically, the weight of the uterus in a non-gravid state is around 60 to 80 grams, whereas weight of a gravid uterus can become up to 1 kilogram, that is nothing but 1000 grams. Okay. What happens in the uterus is that throughout the life of a woman, the corpus cervix ratio changes constantly. Okay. So corpus cervix ratio. Okay. So at different stages, the ratios are like at birth, this is 1:1, and before puberty, this is around 2:1, and what becomes after puberty is this becomes 1:2, and during her reproductive life, this is around 1:3, and after menopause, this becomes 1:1. Understood? So, we'll see what are the structures that is present in the upper part of the uterus. Okay. So, not only the fallopian tube, here we have a ligament called as round ligament. Okay. And also one more ligament, that is nothing but the ovarian ligament. Okay. So, this is the round ligament and ovarian ligament. We see two structures in the corner of the uterus, number 1 and number 2. Okay. So, if we take, this is from anterior to posterior. So, this is the round ligament and this is the ovarian ligament. Okay. So, we will see the structure order. So, from anterior to posterior, okay, first one we will have the round ligament, then we will have the fallopian tubes, then we will have the ovarian ligament. Okay. So, this is one view of the uterus. Suppose if you view the uterus from superior, okay. So, in the superior view, what happens is fallopian tube is at a higher level when compared to the round and ovarian ligament. So, it will be like this. So, the round and ovarian ligament lies at one level, whereas the fallopian tubes, which is in the center of the round and ovarian ligament, are seen at a higher level. Okay. So, this anatomy is very important in tubal ligation, because the most important cause of tubal ligation is the clamping and ligating of round ligament instead of the fallopian tubes. Now, we will see the importance of isthmus. So, isthmus, as I have already told, it is basically the connection between the body and the cervix, and normally in a non-pregnant state, isthmus measures around only 0.5 centimeters. The importance of isthmus happens during pregnancy. What happens in pregnancy is that this isthmus is capable of expanding and it becomes the lower uterine segment. Okay. And even during labor, if you see, the isthmus can measure up to 10 centimeters during labor. Okay. So, I hope you have understood. So, this is the pic to make a better understanding. Okay. So, basically, so this is the body of the uterus. Okay. So, this is the fundus of the uterus and we have the cervix down here, that is projecting into the vagina. Okay. So, this is the endometrial cavity. Okay. Now, we will see the anatomical relations of the uterus. See, basically, we will have the uterus like this. Okay. Posteriorly, we have the rectum and anteriorly, we have the bladder. Okay. This is the bladder, this is the uterus and this is the rectum. Uterus is being surrounded by a peritoneal layer. Okay. So, this peritoneal layer surrounding the uterus, what happens is the peritoneal layer in the posterior wall, it's going to form a recto-uterine pouch, okay, or the pouch of Douglas that is present between the uterus and the rectum. Okay. So, this pouch is known as recto-uterine pouch, just between the rectus and the uterus, or it is also known as pouch of Douglas. Okay. And here in the anterior wall also, there is one deficient space without peritoneum is seen. Okay. So, this deficient space is the region where we give incision during LSES. And the importance of recto-uterine pouch is that in case of pelvic inflammatory disease, there can be fluid collection in this pouch of Douglas, and this can also happen in ectopic pregnancy. Okay. We'll see how the position of the uterus is in the pelvic cavity. Basically, most of the times, that is 80% of the women have their uterus anteverted and anteflexed. So, what is this angle of anteversion? Angle of anteversion is the angle that is present between the longitudinal axis of the vagina and the longitudinal axis of the cervix. This angle normally measures around 90 degree. Next comes angle of anteflexion. Angle of anteflexion is the angle that is present between the longitudinal axis of uterus and the longitudinal axis of cervix. This angle normally measures around 120 degree. Okay. So, if you see this picture, you will be able to understand the angle of anteversion and anteflexion. So, this is the vagina. Okay. So, this is the vagina, this is the cervix we have. Okay. Basically, the angle of anteversion is the angle that is present between the longitudinal axis of vagina and the longitudinal axis of cervix. Okay. So, this angle normally measures around 90 degree. Okay. So, 90 degree. And angle of anteflexion is the angle that is present between the longitudinal axis of the cervix and the uterus. Okay. So, this angle measures around 120 degree. Okay. Remaining 20% of the women can have their uterus as a retroverted organ. Okay. So, that is the fundus of the uterus is not going to come anteriorly, the fundus is going to lie posteriorly. Okay. So, in that case, what happens is there can be retention of urine. Understood? So, we will see what is the difference between anteverted uterus and a retroverted uterus. So, anteverted uterus and retroverted uterus. Okay. So, in anteverted uterus, if you do a pervaginal examination, you will be able to palpate the cervix posteriorly. Okay. Whereas in a retroverted uterus, the cervix can be palpated anteriorly. When you do a per-abdomen examination, the fundus of the uterus can be palpated. Okay. But in the retroverted case, the fundus of the uterus cannot be palpated. Okay. Next, we will see what are the layers of the uterus. We have the outer perimetrium, middle myometrium, and inner endometrium. Okay. We'll see one by one layer now. Okay. First, we'll see the outer perimetrium. Parametrial layer. Okay. So, we'll see a pic for better understanding now. So, we have the uterus here. Then we'll have the rectum posteriorly. Tolerate my diagrams I am not a good drawer actually. And we have the bladder anteriorly, right? Okay. Now what happens is the perimetrium is the single layer of peritoneum that is surrounding the uterus. Okay. It basically surrounds the uterus like this. Okay. There is one deficient part in the anterior region. Okay. And what happens is this layer comes like this and it is going to form one pouch like structure between the uterus and the rectum. Okay, so this region is basically called as the pouch of Douglas or rectouterine pouch. Okay, now this pouch of Douglas or rectouterine pouch is very important because in cases of pelvic inflammatory disease or ectopic pregnancy, what is going to happen is there will be fluid collection. Okay, in this region. So basically this can be tested by using two procedures. One is culdocentesis, where the fluid can be aspirated with a needle, and the second procedure is colpotomy, where we will be giving an incision and draining the fluid collection. Okay. And this region of deficient peritoneum in the anterior uterine wall is where we give incision during LSCS. Understood? Now we will see the middle myometrium. In the myometrium, again we have three layers. Okay. So the layers include outer longitudinal muscle fibers, middle crisscross muscle fibers, and the inner circular muscle fibers. Okay. So this is a picture for better understanding. So we have, these are the layers, okay, of myometrium. We have the outer layer, that is outer longitudinal muscle fibers, and middle layer where is a crisscross arrangement of the muscle fibers, that is basically a mesh-like fibers, and in the inner layer we have a circular layer of muscle fibers. Okay. Now this outer layer of muscle fibers is also going to continue via the ostium. Ostium is nothing but the medial opening of the fallopian tubes into the uterine cavity. So it is going to continue into the fallopian tubes. Middle crisscross fibers are very important structures in the myometrium because these are also known as living ligatures. Middle crisscross fibers are very important because what happens is, if the fibers are like this, you will have the spiral arteries being opening into the fibers like this. Okay. So what happens soon after delivery, these crisscross fibers are going to contract and compress these myometrial vessels. Okay. Suppose if this contraction is not happening, then it can lead to PPH. So this middle crisscross fibers are also known as living ligatures. Okay. Inner muscular fibers are not that much significant. Now we'll come to the endometrium. The endometrial layer of the uterus basically consists of a single layer of columnar epithelium. Okay. Endometrium thickness constantly changes during the menstrual cycle. If you see, around ovulation, the endometrium thickness is around 5 to 6 millimeters, and in the secretory phase, this becomes around 6 to 8 centimeters, 6 to 8 millimeters. And after menstruation, this becomes only 0.5 millimeters. And whenever implantation is happening, okay, the thickness can rise to 10 to 12 millimeters. And the normal post-menopausal cutoff of the endometrial thickness is around 4 millimeters. Okay. Now, whenever a blastocyst is getting implanted in the endometrium, this endometrium will be converted into something called as deciduva. Okay. So, basically deciduva is nothing but the endometrium of pregnancy, and this process is known as decidualization. Okay. So, if you take the layers of endometrium, in a non-pregnant state, it has two layers, namely functionalis layer and basalis layer. Okay. So, functionalis layer is the layer that is normally shed during menstruation. Okay. Now, what is the function of this basalis layer? Basalis layer is going to regenerate the endometrium after the menstrual shredding. Can you understand? Yes. Now, we will see the layers of deciduva. So, what is deciduva? Yes, it is nothing but the endometrium of pregnancy. Deciduva, we have three layers, namely deciduva basalis, deciduva parietalis and deciduva capsularis. Okay. So, if we see a diagram, see just like this, we have the uterus. Okay. So, this is where the blastocyst is getting implanted. Okay. What happens, what type of implantation happens in humans? It is a interstitial implantation, right? It is a interstitial implantation. So, this blastocyst is going to bury into the endometrium. Okay. So, as it buries down, so it is surrounded, it becomes surrounded by one layer of endometrium upside and another layer of endometrium down. Okay. So, basically this endometrium that is present down, okay. So, this is the deciduva basalis. Okay. The covering or a cap-like structure which is surrounding the blastocyst, this is the deciduva capsularis. So, this is the deciduva capsularis, and the rest of the endometrium, okay, it is the deciduva parietalis. Understood? So, for a better understanding, you see this picture. So, this is where the blastocyst has implanted. This region of the endometrium is the deciduva basalis. It is surrounded by a cap-like structure of endometrium, that is deciduva capsularis. The rest of the endometrium is the deciduva parietalis. Okay. Now, decidua parietalis and capsularis, or together known as decidua vera. Okay. And decidua bassalis and decidua parietalis is further divided into three layers, namely the stratum basale, stratum compactum and stratum spongiosum. Okay. So, these are the various layers of the decidua bassalis and the parietalis. We have the stratum compactum, stratum spongiosa, and this is the stratum basale. Okay. Stratum compacta and spongiosa are together known as stratum functionale. Okay. So, just like how the bassalis layer is going to regenerate the endometrial layer after menstruation, after the shedding up of the decidua. Okay. So, the decidua will be basically shed in this plane, okay, between the bassalis layer and spongiosa layer. So, this is the functionalis layer that is being shed, and the stratum basale is going to regenerate the endometrium again. Okay. Next, we will come to the cervix. Cervix is basically made of connective tissue. Okay. It is around 3 to 4 centimeter in length normally, and suppose if it is less than 2.5 centimeter in length, it is known as short cervix. So, we have the uterus. Okay. So, imagine this is the cervical part. Okay. So, we can divide the cervix again into two parts. Okay. First part is the portio supravaginalis, and the second part that is descending into the vagina is the portio vaginalis. Okay. Now, we have two os of cervix. One is the internal os, okay, and another one is the external os. Okay. Internal os is nothing but that is present inside, okay, the opening of the portio supravaginalis. External os is something that is opening exteriorly into the vagina. The lining of cervix is also important. Okay. So, basically we divide the cervix again into endocervix and ectocervix. Okay. So, this is the endocervix that is present between the two os, and this is the ectocervix or exocervix that is present outside, okay, the outer layer. Understood? Now, lining of cervix is very important. Okay. So, in the ectocervix, it is lined by stratified squamous epithelium, and the endocervix is lined by columnar epithelium. Okay. The junction between these two layers, okay, so the junction between the two layers of epithelium. What are the two layers between the? Yes, it is the stratified squamous epithelium and the columnar epithelium. Okay. So, this is known as what? Yes, very good. It is the squamosepithelium. columnar junction. Okay. Now this columnar junction, it is not a constant one. This junction level also changes during the various stages of the women. Okay. As the woman gets older, this junction is going to go inwards. Okay. So, for example, if this junction is present here, okay, imagine first it is present here at this level. As the woman is getting older, this is going to ascend up and up. Okay. So, we have another terminology, that is transformation zone. Okay. What is transformation zone? The region between the old and new columnar junction is known as the transformation zone. Okay. In this region of transformation zone only, most of the time metaplasia happens, which can give rise to carcinoma cervix. Okay. And another point is that sometimes there can be follicles, namely nabothion follicles, that can be formed in the cervix. This is due to entrapment of the squamous epithelium. Okay. So, this is basically a benign condition. And if you see a cervix through a perspeculum examination, normally in a nulliparous woman, the os is circular in shape. Okay. If you see it in a parous woman, this will be a transverse slit-like opening. Okay. So, this helps to differentiate between a nulliparous cervix and a parous cervix. Okay. Now, we will see the ligaments of uterus and cervix. Number 1, it is the round ligament. Number 2, broad ligament. Number 3, infundibulopelvic ligament. Number 4, caudinal ligament. This ligament is also known as Macentrodot's ligament or transverse cervical ligament. And finally, we have the pubocervical ligament. First, we will see round ligament. Round ligament of uterus is basically similar to the gubernaculum of testis. Okay, similar to that. Okay, what happens is this round ligament, it starts from the cornua of the uterus. Okay, it descends down and reaches the broad ligament, becomes a structure of broad ligament. Then it becomes a retroperitoneal structure and travels in the inguinal canal. Okay, so one of the contents of inguinal canal in females is a round ligament. In the round ligament, it is seen with the Samson's artery. Okay, it travels with the Samson's artery. And after that, it will exit the pelvis and comes and lies at the anterior 1/3 of labia majora. Okay. Now what is the importance of this round ligament? Round ligament is the most commonly ligated wrongly when they do tubal ligation. So basically while doing tubal ligation, you have to identify the tubes properly. So how will you identify the tubes? By using the fimbrial end. Okay. So it should not be mistaken with the round ligament. Okay. So this is the most common cause of failure of tubal ligation. And other point is that there can be enlargement of this ligament in pregnancy due to hypertrophy, and this can lead to pain. So we'll see the position of the round ligament. Okay, so this is the uterus. We have the round ligament over here. Then we have the ovary under the fallopian tube. Okay. Next ligament is the broad ligament. Basically, broad ligament is a wind-like structure. Okay. This is nothing but the we'll see the next structure. That is the broad ligament of uterus. Broad ligament of uterus is a wing-like structure. It extends on either side of the uterus. On cross section, you will see this broad ligament in a inverted triangle shape. Okay, so to make you understand, so this is the broad ligament. Okay, so this structure is the broad ligament. Okay, so this is in an inverted triangular shape with the base in the superior side and apex parting downwards. Okay, so what are the contents of broad ligament? It is the fallopian tubes, round ligament, ureter at the base. Also it consists of the arteries and veins and lymphatics of the uterus. Broad ligament also divides the space of the pelvis into anterior and posterior parts. Okay. And what is the important point you have to know is both the round ligament and broad ligament, they are not support of uterus. Okay. Now, broad ligament is basically the peritoneum layer that is surrounding the uterus and the surrounding structures. So, mesosalpinx is that layer of broad ligament that is surrounding the tubes. Myometrium is the layer of broad ligament that is surrounding the uterus, and meso-ovarium is that part of the broad ligament that is surrounding the ovaries. Third ligament is the infundibulopelvic ligament. Now this ligament extends from extends from the, this ligament extends from the ovaries to the pelvic wall. Okay. So, this is the infundibulopelvic ligament. This is also known as suspensory ligament of ovary. So, what is the importance of this ligament is, suppose if you want to perform oophorectomy along with hysterectomy, this ligament has to be cut. Okay, so that the ovaries will be removed along with the uterus. Suppose if you want to retain the uterus, then you have to cut the round ligament over here. Okay. Next, we will see about the infundibulopelvic ligament. This ligament is also known as suspensory ligament. So, if you take, this is the pelvic wall, these are the ovaries, and say we have the uterus over here. Okay, uterus like this. Okay, so this ligament extends from the ovary to the pelvic side wall. Okay, so this is the infundibulopelvic ligament. The importance of this ligament lies in, suppose if you want to perform oophorectomy along with hysterectomy, you have to cut this ligament. Next one is the caudinal ligament, or it is also known as Maconrodus or transverse cervical ligament. This ligament is basically lies at the base of the broad ligament. Next one is the pubocervical ligament. From the name itself, you will be able to get, that is, it extends from the anterolateral part of cervix, okay, to the pubic bone. Okay. So, these are the various ligaments seen around the uterus and the cervix. Now, we will see the blood supply of uterus and cervix. So, we have the aorta, and the aorta divides into two branches at the level of L4. So, these are the common iliac arteries, and the common iliac arteries further divide into the internal iliac and external iliac artery. Okay. Now, internal iliac artery lies posterior and medial to the external iliac artery. Again, this internal iliac artery divides into anterior division and posterior division. Okay. So, we have to know about the branches of internal iliac artery. So, this is the picture. Okay. We have, so this is the anterior branch. Okay. So, this is the anterior branch and these are the posterior branches. Okay. So, iliolumbar artery, internal iliac artery and lateral sacral artery are the posterior divisions branches. Okay. And all these arteries, say the superior gluteal artery, okay, inferior gluteal artery, the internal pudendal artery, middle rectal artery, uterine artery, superior vesical artery and the umbilical artery, or also the obturator artery. Okay. So, these arteries are the branches of anterior division of internal iliac artery. Okay. So, you have seen this artery, that is the uterine artery. So, this is the artery that is going to supply the uterus and the cervix. Now, how does this artery is going to supply the uterus and cervix? So, we will see how the uterine artery is going to supply the uterus. So, this is the uterus, imagine this is the uterus. So, this is the uterine artery that is coming down to supply the uterus. Okay. At a distance of 2 cm from the cervix, it crosses the ureter. Okay. Basically, this relationship is defined as water under the bridge. Okay. So, which is the water here? It is the urine that is contained inside the ureter. Bridge basically denotes the uterine artery. Okay. So, this uterine artery crosses the ureter at a distance of 2 cm from the cervix, and then it gives a descending cervical branch to supply the cervix, and then it takes a turn upwards. As it passes upwards, it will be giving numerous branches that will be supplying the different layers of the uterus. Okay. So, these branches of uterine artery can be remembered by the mnemonym ARBs. Okay. So, these branches are basically arcuate artery, from which comes the radial artery, then it's the basal artery and the spiral artery. Arcuate artery supplies the myometrial surface. Radial artery supplies the myometrium. Basal artery and endometrial artery supplies the endometrium. Okay. So, this is a picture for better understanding. So, what is going to happen is, this is the uterine artery as it descends down, okay, and it gives a vaginal branch, cervico-vaginal branch. This is because it supplies the cervix as well as the vagina. Then it ascends down like this, okay, and it gives numerous branches to the uterus, tubes, and also it anastomoses with the ovarian artery that is coming from the aorta directly. And what happens to this internal iliac artery after giving all these branches? Finally, the internal iliac artery becomes the internal pudendal artery. And it terminates as dorsal artery of clitoris. Okay. So, this is one picture to understand the various branches of uterine artery. Number 1, this is the arcuate artery, and okay, so these are the radial arteries, and these are the basal arteries, and these are the spiral arteries which are seen supplying the functionalis layer of the endometrium. Then coming to the venous drainage. Venous drainage is along the same path as the blood supply. So, it starts from the uterine veins which drain into the internal iliac veins, which drain into the common iliac veins, and finally the inferior vena cava. Coming to the nerve supply. Nerve supply of the uterus is by the Frankenhauser plexus of nerves, or otherwise this is known as hypogastric plexus. So basically it consists of T10 to L1 nerve roots. So if you want to block pain during first stage of labor, we have to block this T10, and this can be done during epidural analgesia. For LSES, we have to give block from a higher level, and this block will be done from T4. If we want to block pain during second stage of labor, we have to block the pudendal nerve, okay, whose root value is S2, S3 and S4. Finally, coming to the lymphatic drainage. So this is the Frankenheiser plexus of nerves. This is basically situated in the uterosacral ligament. Okay, we'll see the lymphatic drainage. Suppose we consider this is the uterus. Okay, the fundus is going to drain into the parietic nodes. The corpus or the body of the uterus is going to drain into the parietic nodes as well. The cervix along with the upper part of the vagina, upper 2/3 of the vagina, is going to drain into the pelvic lymph nodes, which will be draining into the external iliac, internal iliac lymph nodes, finally into the common iliac lymph nodes, and they will drain into the parietic nodes as well. Okay. So this is all about the anatomy of the uterus and cervix. Until we meet in the next video, take care and bye bye.